Hello everyone. In this class, we'll try to discuss about the factors affecting and regulating cardiac output. The objectives are to describe the factors affecting cardiac output and explain the regulation of cardiac output. The factors affecting stroke volume are it is affected by the preload as well as afterload. Preload end diastolic volume is considered as a measure of preload. Increase in end diastolic volume increases stroke volume and decrease in end diastolic volume decreases stroke volume. Frank-Starling's law. Frank-Starling's law of the heart states that within the physiological limit, the force of contraction is directly proportional to the initial length of the muscle fiber. The initial length of the muscle fibers means the fiber length prior to the ventricular contraction. The muscle length prior to contraction depend on the level of stretch of the ventricular mass at the end of diastole. Increased ventricular filling increases the fiber length that increases the force of contraction. This is also known as heterometric regulation of cardiac output, as the stroke volume varies at various fiber length. This is going to state the force Frank-Starling's law. As the end diastolic volume increases proportionately, the stroke volume is going to increase within up to the physiological limit. These are the factors affecting the preload. These are venous return, atrial pump activity, and ventricular compliance. Coming to venous return is defined as the amount of blood that returns to the right atrium from systemic venous circulation. Venous return depends on many factors. Important them are skeletal muscle pump, thoracic pump, abdominal pump, the extracellular fluid volume, sympathetic activity, right atrial pressure, degree of filling of systemic circulation, and resistance of blood flow in venous system. Skeletal muscle pump. The limb veins contains walls that open only towards the heart. Therefore, contraction of skeletal muscle compresses the veins and pushes the blood towards the heart. This increases venous return. Thus, the cardiac output increases by increasing skeletal muscle activities, for example, during walking. On the contrary, during quiet standing for a longer period, pooling of the blood occurs in the leg veins due to the absence of muscle activity that decreases the venous return, which in turn decreases cardiac output. Quiet standing for a longer period decreases the cardiac output and sometimes may cause fainting. Therefore, traffic police personnel are usually advised to walk around the traffic to make their limb movements frequently while performing their duties for a longer period. This is how the blood is pumped in a unilateral direction in a muscle. The walls are they are present like this, and which are going to cause a unidirectional flow of blood. Okay, so when pressure increases in this compartment, these are going to close these walls. Thoracic pump. Venous return increases during inspiration due to thoracic pump activity. During inspiration, the intrathoracic pressure becomes more negative due to the expansion of the thoracic cage, which is transmitted to the great veins. Therefore, central venous pressure falls. The fall in venous pressure during inspiration facilitates venous return. Abdominal pump. During inspiration, intra-abdominal pressure rises due to the descent of diaphragm. The increased abdominal pressure compresses the intra-abdominal blood vessels so that blood is pushed towards the heart. Blood is not pushed towards the leg vein as they are guarded by the venous walls. Thus, the venous return increases. ECF volume. The venous return greatly depends on the extracellular fluid volume, especially the plasma volume. Decrease in the ECF volume occurs in diarrhea, vomiting, and that decreases the cardiac output. Increase in the ECF volume as it occurs in pregnancy increases the cardiac output. Sympathetic activity. Veins are innervated by the sympathetic fibers. Stimulation of sympathetic system causes venoconstriction, which in turn increases venous return. This is the one of the mechanism of increased cardiac output in exercise. Decreases sympathetic stimulation causes venodilatation that decreases the cardiac output due to increased venous pooling of the blood. Right atrial pressure exerts backward force on the veins to impede the flow of blood from the veins in the right atrium. Within the normal range, the right atrial pressure is 0 to 6 mmHg. With the increase in the pressure, venous return decreases steadily. Venous return is 0 above 7 mmHg of right atrial pressure. With the decrease in the right atrial pressure, there is a proportionate increase in the venous return. When right atrial pressure falls below 0, increase in the venous return is slowed, and further increase in venous return does not occur when right atrial pressure falls below minus 2 mm of Hg. There will be a plateau in venous return curve. Venous return curve remains at this plateau level when right atrial pressure falls even to as low as minus 20 mm of Hg to minus 50 mm of Hg or even further. This plateau is due to collapse of vein in the chest. A high negative pressure in the right atrium sucks the walls of the veins in the chest and veins collapse. This prevents any additional flow of blood from the peripheral vein into the right atrium. Therefore, more negative pressure below minus 2 mm of Hg in the right atrium cannot increase the venous return significantly. Degree of filling of systemic circulation. Degree of filling of the systemic circulation forces the systemic blood towards the heart. This is mainly the effective blood volume that fills the circulation and distends the vascular wall. This is measured by mean systemic filling pressure. The mean systemic filling pressure can be theoretically measured everywhere in the systemic circulation when the entire blood flow in the vascular tree is stopped by temporarily stopping the heart to pump blood. Without blood flow, the pressures everywhere in the circulation becomes equal. This equilibrated pressure level that fills the entire circulation is called as mean circulatory filling pressure, and the normal mean circulatory pressure is around 7 mm of Hg. Then resistance to venous return. Resistance to flow of blood between peripheral vessels and right atrium is called as venous resistance. That is resistance to venous return. When venous resistance increases, as in venous obstruction, the blood begins to be damped up, mainly in the venous compartment. But rise in the venous pressure to overcome the resistance occurs little as the veins are highly distensible. When resistances increase arterioles and small arterioles, blood accumulates in arteries. But as they have less capacitance, even slight accumulation of blood in arteries raises the pressure greatly. High pressure in the arteries overcome much of the increased resistance. Atrial pump activity. The ventricular filling occurs mostly passively. About 50 to 20% of the ventricular filling at rest occurs due to the atrial contraction, that is, atrial pump activity. Therefore, normally atrial pump does not contribute significantly to the stroke volume. However, in conditions of increased demand of cardiac output as occurs in exercise, the atrial systole contributes significantly to the end diastolic filling of the ventricle. However, in patients with atrial fibrillation, cardiac output does not rise significantly in such conditions. The atrial contraction increases by sympathetic stimulation. Then ventricular compliance. Normally, the ventricular muscle is compliant, that is stretchable, enough to accommodate the adequate blood during diastole. The normal end diastolic volume is 130 ml. In cardiomyopathies or infiltrative disease of heart, ventricular filling decreases due to the decreased compliance of the ventricular muscle. Thus, cardiac output decreases. Sometimes the ventricular muscle may be compliant, but there is restriction to the distension of ventricles due to pressure from outside as it occurs in constrictive pericarditis or pericardial effusion. The end diastolic volume decreases. In pericardial effusion, the fluid accumulates in excess in pericardial cavity, which increases intrapericardial pressure that prevents ventricular expansion and decreases end diastolic volume. In cardiac tamponade, as it occurs in massive pericardial effusion or hemopericardium, the end-diastolic filling may be reduced severely and stroke volume is decreased to a dangerously low level. Myocardial contractility. It exerts a major influence on the cardiac output. Factors that increase myocardial contractility are said to be positively inotropic, and factors that decrease myocardial contractility are said to be negatively inotropic. Myocardial contractility depends on mainly the ventricular muscle mass, state of autonomic activity, concentration of various hormone and chemicals in the blood, drugs, and heart rate. Factors that stimulate contractility shifts the curve to the right side, and the factors that inhibit contractility shifts the curve to the right side. Okay. So these are the Frank-Starling curves, and this shows the end-diastolic volume relation of end-diastolic volume with the stroke volume. Okay. So with the sympathetic activity, it is going to turn to the right side, and decrease in the sympathetic activity, it is going to shift the curve to the left side. So again, the myocardial contractility depends on the many factors: the circulating epinephrine, norepinephrine, the various drugs, the partial pressure of oxygen, carbon dioxide, and pH, the injury to the myocardium, various factors which are going to affect the myocardial contractility. Myocardial mass is important in determining stroke volume. Ventricular mass decreases either due to loss of myocardium, as it occurs in myocardial infarction, or due to the muscle atrophy which is seen in some cardiomyopathy. In such condition, cardiac output decreases significantly. Increase in myocardial mass increases cardiac output. The common physiological condition of increased ventricular mass is the regular practice of physical exercise. In strong athletes, heart size increases due to the physiological hypertrophy of myocardium. In these individuals, cardiac output increases during exercise by mainly increasing the stroke volume rather than the heart rate. Autonomic activity. Ventricles are supplied by sympathetic fibers. Sympathetic stimulation increases ventricular contractility, and sympathetic inhibition decreases. Ventricles are sparsely innervated by vagal fibers. Therefore, vagal stimulation has less effect on myocardial contractility. However, vagal stimulation decreases cardiac output mainly by decreasing the heart rate. Then hormonal factors, catecholamines are positively inotropic. They act on beta-1 adrenergic receptor in the ventricles. The increased adenyl cyclase activity increases cyclic AMP formation in the muscle cell. Cyclic AMP increases intracellular calcium concentration, which in turn increases myocardial contractility. Acetylcholine acts on muscarinic receptors and decreases intracellular cyclic AMP concentration. Thus, acetylcholine decreases myocardial contractility. Glucagon increases the intracellular cyclic AMP. Glucagon is a potent inotropic agent and sometimes used clinically to enhance myocardial performance. Insulin is inotropic. Thyroxine, it increases the number of beta-1 receptor in the nodal tissues and ventricular muscles. It increases the sensitivity of these receptors to catecholamines. Thus, thyroxine produces tachycardia and increases myocardial contractility. Thyroxine also increases myosin ATPase activity in the ventricular muscles, which significantly increases myocardial contractility. Chemical factors like xanthines, such as caffeine and theophylline, are positively inotropic. They inhibit intracellular breakdown of cyclic AMP so that high concentration of cyclic AMP is maintained in the ventricular muscle mass. Some of the inhibiting factors suppresses the myocardial contractility, that are hypercapnia, hypoxia, acidosis, general anesthetics, and toxins. Digitalis increases the myocardial contractility by inhibiting the sodium-potassium ATPase activity on the membrane of myocardial cells. This increases intracellular concentration of sodium that opposes the sodium gradient across the membrane from outside to inside the cell. Decreased sodium gradient decreases the activity of sodium-calcium exchanger on the membrane, as normally the sodium is taken in and calcium is taken out through this exchanger. Decreased exchange of these ions leads to intracellular accumulation of calcium, increases the muscle or myocardial contractility. The other drugs like quinidine, procainamide and barbiturates inhibits myocardial contractility. Then this is about the preload. Coming to the afterload. Afterload is the force against which the ventricular muscle fibers shorten. Essentially, it is resistance offered against ejection of blood from ventricles. Peripheral resistance is considered as afterload. Cardiac output is inversely proportional to the afterload. Thus, increase in peripheral resistance decreases cardiac output, and decrease in peripheral resistance increases cardiac output. In this process, cardiac output is altered without change in the ventricular muscle length. Therefore, this type of regulation of cardiac output is called as homometric regulation and is also known as Arnep effect. Factors which are affecting the afterload: the vessel diameter. The decrease in vessel diameter, that is vasoconstriction, increases the peripheral resistance, that decreases the stroke volume. Stroke volume increases in vasodilatation due to decreased afterload. The increased viscosity as it occurs in polycythemia increases the peripheral resistance and therefore decreases cardiac output. Cardiac output increases in anemia due to decreased viscosity. Factors which affects the heart rate, they are going to affect the cardiac output. The vagal stimulation decreases the heart rate and sympathetic stimulation increases the heart rate. Normally, increase in heart rate should be result in increased cardiac output, as the cardiac output is the product of heart rate and stroke volume. However, unless associated with increased venous return, increase in the heart rate may not increase the cardiac output proportionately. In severe tachycardia, duration of diastole shortens more than the duration of systole. Therefore, ventricles get less time to be filled. Thus, end diastolic volume decreases. Consequently, cardiac output does not increase proportionately to that of increase in the heart rate. So, this is going to summarize the factors affecting the cardiac output. The cardiac output is going to be dependent on the stroke volume and the heart rate, and the stroke volume depends on the preload and the afterload factors. Some of the factors affecting the preload are venous return, ventricular compliance, and atrial pump, whereas the afterload, which is going to decreases the stroke volume, depend on the vessel diameter and the viscosity of the blood. And in fact, the stroke volume is directly proportional to the myocardial contractility, and this in turn depends on the muscle mass, sympathetic activity, hormones, drugs, and some of the chemical factors. Coming to the regulation of cardiac output, there can be intrinsic regulation and extrinsic regulation. Intrinsic regulation is also called as autoregulation of cardiac output. Two principal intrinsic mechanisms regulate cardiac output. These are Frank-Starling's mechanism and rate-induced regulation. Frank-Starling's mechanism: increase ventricular volume, that is end diastolic volume, increases ventricular contraction, that is stroke volume, and decrease end diastolic volume decreases stroke volume. This effect can be demonstrated even in the denervated heart. Therefore, regulation by change in preload is purely an intrinsic mechanism. Such type of regulation of cardiac output by change in the ventricular muscle length at various ventricular volumes is known as heterometric autoregulation of the heart. Rate-induced regulation: with increased frequency, the force of contraction increases. This is due to the accumulation of the intracellular calcium concentration, which occurs due to the increase in the number of depolarization per minute. Calcium ion enter the myocardial cells during the plateau phase of action potential. Thus, with increase in the number of action potential, the calcium entry into the cell mass increases in spite of decrease in the duration of the action potential. There will also be increase in the inner calcium current per depolarization. As the interval between the beats is diminished due to the increased frequency, the inner calcium current progressively increases with each successive beat, which increases the force of contraction. Coming to the extrinsic regulation, it can be because of the afterload or the neural control. The change in the peripheral resistance afterload alters the cardiac output. The increase in the afterload decreases the cardiac output, and decrease in afterload increases cardiac output. This type of regulation is known as homometric regulation of the heart, as cardiac output is altered without change in the muscle length. Neural control. Sympathetic influence. Stimulation of sympathetic nerve to the heart increases the heart rate and myocardial contractility that increase the cardiac output. Sympathetic stimulation also causes venoconstriction that increases the venous return, which also contributes to the increase in the cardiac output. The parasympathetic influence. The parasympathetic stimulation decreases cardiac output mainly by decreasing heart rate. Ventricular contractility is marginally decreased as vagal innervation of ventricle is sparse. There can be humoral control, regulation of hormones, regulation by hormones and chemicals. Hormonal regulation, or rather humoral regulation by catecholamines, thyroid hormones, insulin, glucagon, and growth hormone are going to regulate the cardiac output. The adrenomedullary hormones, the hormones secreted from the adrenal medulla like epinephrine, norepinephrine, and dopamine, increase myocardial contractility and heart rate, thus cardiac output increases. Insulin has a direct inotropic activity on the heart. Thyroid hormone, thyroxine, increases cardiac output by following four mechanisms. By increasing the myosin ATPase activity, it increases the excitation contraction coupling. It increases the number of beta receptors and sensitivity of the receptors to catecholamine in the nodal tissues and the ventricular muscles. Thus, heart rate and myocardial contractility increases. It increases the protein synthesis in the myocardial cells that causes ventricular hypertrophy. Increased ventricular muscle mass increases myocardial contractility. It increases body metabolism. The increased body temperature causes vasodilatation that in turn decreases peripheral resistance. Decreased afterload increases the cardiac output. Glucagon has both positive inotropic and chronotropic effect. It acts by increasing intracellular cyclic AMP. Cyclic AMP increases calcium concentration in the myocardial cells by two mechanisms. Firstly, it increases calcium influx by opening calcium channels on the cell membranes, and secondly, it increases calcium release from the sarcoplasmic reticulum. Growth hormone increases the cardiac output by increasing the myocardial contractility. Coming to chemical regulation, the mild hypoxia causes tachycardia. Moderate to severe hypoxia decreases the cardiac output, directly suppressing the myocardial contractility and also by stimulating the peripheral chemoreceptors. Carbon dioxide has a direct and indirect effects on myocardium. Directly, it depresses the myocardium. The indirect effect is neurally mediated through its action on central and peripheral chemoreceptors. Acidosis depresses myocardium. The reduced intracellular pH diminishes the amount of calcium released from the sarcoplasmic reticulum and also decreases the sensitivity of the myofilaments to calcium. Increase in intracellular pH has the opposite effect. So these are some of the factors which are going to affect the cardiac output, and this is how the cardiac output is regulated by intrinsic and extrinsic mechanism. Thank you.